those of you who don't know me, my name is Angie Wright. I am an emergency medicine doctor and an EMS physician. I work clinically at the University of Colorado Hospital, do some medical direction, but that's becoming less and less on the agency side, and then do some other more government-y type things in my spare time. I'm really excited to be on here with a bunch of my colleagues from the University of Colorado and UC Health, and I'm going to have them introduce themselves, as well as some of our representation from Ray, Colorado, where we do medical direction. I'm going to kind of throw it out there what we're going to do tonight, and Andra, please feel free to jump in and correct me, as your understanding of this might be different than mine. Our idea, we wanted to do something a little different with the way we do REES. So we're trying this special session. So I'm the representative physician. We have Jason Welch, who's our representative EMT, just turned his camera on, hello. We have Ryan Shelton, who's our representative paramedic. And we have Mandy Krikora, who's our critical care paramedic. And we, the four of us providers, have absolutely no idea what the cases are that are about to be given to us. So we have had no preparation. We have no idea what the calls are. Dr. Farkas has been working with our education team, and they have created some calls that we're going to run. And our hope and idea is that we're going to start with our EMT first responder. He's going to walk us through what he's thinking about, what he would do on scene. He'll transition care either on his own, or when Andra says switch or whatever the magic word is, to Ryan. Ryan will take care of this patient for a while. He'll probably call a helicopter maybe at some point, which will give it to Mandy, and then Mandy will bring the patient to me in the hospital. So it should be a little fun. My hope is to have some fun with it. Please pipe up, ask questions. We've never done this before, so be kind and bear with us as we try to figure it out and as we see how this model goes. So Dr. Farkas, and then actually let's do quick intros for everybody on that I just kind of introduced, Mandy, Ryan, and Jason, little backgrounds, and you too, Andra, and then we'll kick it off.
I'm Ryan Shelton. I'm the EMS manager for UC Health. I have a background with South Metro for many, many decades, and am now there at UC Health.
My name is Jason Welch with City of Ray EMS. I've been with them for 6 years, been an EMT for 5 years plus, IB cert for about 3.5. Got into EMS just to kind of, exercise my desire to help people and be there when they need people at their, it's having the worst day of their life. I want to be there to kind of help guide them through it.
I'm Mandy Krikora. I'm one of the educators for UC Health's pre-hospital education program. I've been in EMS for going on 23 years, firefighter, EMT, paramedic, light paramedic, and I like to teach.
And I'm Andra Farkas. I'm an emergency medicine EMS doc out of university, do medical direction for a lot of the agencies that I see represented here. So thank you guys for joining. And it's funny, they don't know the cases, and neither do I as the moderator. So no, I'm kidding. So we will see how this goes. All right. So you guys ready? Jason, you ready? Okay. I don't have much to present on the screen, but there may be some stimuli if you ask for it. So there may be stuff on the screen, there may not be. And I'm going to try to watch the chat as well to try to moderate for any questions. But all right, your first case, Jason, you are getting toned out to a 54-year-old female who's complaining of chest pain. It is about 10 o'clock in the morning. The weather is cold but sunny. There's no wind, no precipitation. You're responding to a pretty well-kept single-family residence. There's no safety concerns. BSI, scene safe, we got it. And then as you're on your way, you get a follow-up from dispatch, which is that the patient just returned from walking her dog. She was sitting down when the pain started. And to set up kind of just the scenario you are working in for all of these calls, I will give you kind of distance from the hospital, but you are basically in a system that has no specialty care. So there's no real trauma, sort of maybe like it's not any level trauma center. You don't have a cardiac cath. You don't have pediatric capabilities, not really. So you're just kind of really working with your basic critical access hospital. Okay.
Yep.
All right. So you are on scene. I am your patient. What questions would you like to know?
Okay. Hi, my name's Jason with Ray EMS. Just wanted to kind of see how you're doing today and what's going on. Can you tell me what was happening, or what prompted you to call 911 today?
Yeah. So hi, Jason. I'm Betsy. I was walking my dog today. I walk my dog every morning. And I was okay. And then I got home and I started feeling kind of weak as I was putting the leash away. You know, we had walked, I went up the stairs, and then I just kind of felt not great. I sat down and then I noticed that my heart was kind of beating funny, kind of abnormal.
Can you tell me what's funny? What do you mean by funny? Is it like irregular, or do you feel like you're fluttering, or
Yeah, like just
fast, slow?
funny, like palpitations. I don't know. I can't say. It's funny.
Okay. Okay. Sounds
Nauseous.
good. Nausea? Okay.
Yeah.
Okay. Dispatch, I'd like to go and get ALS en route if I could.
Okay. ALS is on their way.
All right. I'm going to go ahead and do a couple things real quick. I'm going to go ahead and get you hooked up to my monitor, which I have right here beside me. I'm going to put on a blood pressure cuff, go around your arm. You'll feel it kind of pump up and squeeze. Don't worry if it gets too tight, just let me know, and we'll kind of ignore that. You're going to go ahead and get your pulse ox here. I'm going to go ahead and get your pulse and your heart rate and your respirations.
So your heart rate's 126. Your blood pressure is 132/70. Your respiratory rate is 24, setting 96% on room air.
Okay. Breathing a little bit fast there, Betsy, but we're going to go ahead and take care of you real quick. GCS 15. All right. Gosh, let's see here. So you were walking the dog. So that's your onset provocation. So can you kind of move a little bit? Can you do me a favor and move your arms, kind of sit up a little bit straighter, stand up? Does that make the pain feel any worse or better? Or?
Yeah, no, it's the same.
Okay. And how would you describe that pain? Is it like crushing? Is it sharp? Is it, how would you describe that?
It's like my cat sitting on my chest. You know, I got kind of a fat cat, maybe like a 20-pound cat, and that's
What's your cat's name?
Mittens.
Mittens. Okay. Pressure on the chest. Okay. All right. So where is this pain located at? Just in the middle of your chest, or?
Right in the middle.
Okay. Any pain in your back or your arms, your shoulders, your neck, jaw?
No, just nauseous. Just really, really.
Okay. Really nauseous. Okay. All right. Let's see here. Well, we're going to go ahead and do a few more things real quick. A few more questions, if you don't mind. Do you take any medications on a daily basis?
I don't, no.
Don't? Okay. Let's see here. On a scale of 1 to 10, how would you rate this pain? 1 being just, this is no big deal. 10 being, oh my God, this is the worst pain I've ever had in my life.
A 5.
A 5, okay. So 5 out of 10. Okay. All right. So, what if I'm looking at my patient, Ms. Moderator? What's her color, skin color?
She's a little diaphoretic and a little pale.
Okay. Okay.
Looks pretty uncomfy.
All right. All right. Do we have any? Are you going to do a real quick check here? Everything appears to be fine. Head, neck, face, any extremity injuries, anything like that?
None of that. No evidence of trauma.
Okay. No trauma. Okay. All right. I'm going to look at the eyes real quick. And Betsy, if I can look here in your eyes, open up real wide. Perfect. Thank you. And what do I see when I look there?
Your eyes are totally normal. And your ALS just arrived.
Excellent. Hey, Ryan. Hey, Betsy, this is Ryan. He's our paramedic here on scene. He's going to kind of do a few things as well. I'm going to continue to assist you and assist him as well. Ryan, how are you this evening?
Doing good, Jason.
Good. Hey, I'm here with Betsy. This is a 54-year-old female. Chief complaint is chest pain. She was out walking her dog, and when she got home, she went upstairs, and she came back downstairs, and she's basically exhibiting some basic weakness, a little bit nauseous. She's having kind of heart palpitations. Last blood pressure was 132/70. Respirations are 24. Pulse or heart rate of 126. She sat in 96 on room air. GCS of 15. She's describing chest pains as kind of a pressure in the middle of her chest, kind of like a really heavy cat sitting on her, mittens, I believe it was. We have she's described that as about a 5 out of 10 pain. Anything else I can tell you at the moment?
No, that was good. Thank you.
Yes.
So we'll go ahead and grab a pulse rate. Is that a regular 126 or an irregular?
It is a regular sinus tachycardia.
Okay. She's on some oxygen. Any meds, history, and allergies?
I'm not on oxygen. Who said I was on oxygen?
We're going to put you on some oxygen, young lady.
Perfect. So, what would you like? Would you like nasal cannula, or would you like a normal breather?
Let's start with the nasal cannula, please.
Okay.
We'll go 4
about
liters.
4 liters a minute. All right, that's on. Flowing.
And no meds, no allergies, to answer your question.
Any medical history?
Not that I know of, but I mean, I haven't been to the doctor in about 30 years, so.
Okay. And other than the light walking, was there anything else that was going on at the time when you started having the chest pain?
Nope.
Did you get dizzy at all?
A little lightheaded.
Okay. Has this happened in the preceding couple of days or weeks?
Oh, it's never happened.
Okay.
Hey,
Go ahead and
Ryan,
get a 12 lead.
I've got a real quick question for Betsy. You're on any birth control at the moment?
I'm 54 years old, young man.
Well, I mean, I'll take that as a no. So you take a double dose.
Yeah, pull up the 12 lead. Stand by.
And since she's complaining of some shortness of breath with chest pain, we're going to go ahead and give her aspirin since she has no allergies, 324 milligrams.
Aspirin's on board.
And if I'm supposed to be, oh, there we go. I was
Hold
going
on.
to.
All right. You guys see the 12 lead?
Looks like squiggly lines to me. I'll let you interpret this one.
We do have some ST changes of 1 millimeter, 2 consecutive leads. We have inferior, we have reciprocal, V2, V3. So we're going to go ahead and at a 5 of 5 chest pain, we'll do a cardiac alert, and then we'll also start managing her pain and giving her some nitro. So we'll go 0.4 on the nitro.
Okay.
I'm going to get a line prior to administration.
Okay.
And I want to do a right-sided as well.
Okay. You want a right-sided?
Please.
Don't have a right-sided available. EKG.
If I were to hold it up backwards, any change?
Would you like a posterior EKG?
Yes.
I have. Did you already give the nitro?
Depends on if I have my line or not.
I've got the lead a line for you, Ryan. Got in the right AC. We've got an 18. She had really, really great veins because she's extremely physically active.
Okay.
All right. Hold on.
Got a really nice buff cap on that saline lock.
There you go. It's a little bit different size, but that is your posterior EKG.
Okay. We do have posterior involvement as well. I'm going to actually make a phone a friend so we can share the blame on this one if we go ahead with nitro. So I'll call UC Health and I'll hopefully get connected to my medical director.
Dr. Wright, I think he's skipping the.
I was like, is that me or is that you today?
He's skipping
Let's get a follow-up pressure
I'm sorry,
after the nitro.
you did not give nitro.
Yes, that's correct. What's the pressure? We had a 132/70 originally.
Yeah, after administration, her pressure is 70/40. And she says she thinks she's dying. She's a little gray.
Okay, so we'll give her some fluids, lay her down.
Okay, we move her to the cot, get her secured the best we can, put a blanket over it, kind of keep her warm for treatment for any shock just in case.
20 cc's per kilogram.
Okay.
Any change in mentation?
Yeah, let's say you pressure bag that in. She is much better, back to her baseline as we met her earlier, and her blood pressure's
Blood pressure was, you cut out?
120/68.
120/68. I can live with that. And my rate?
Your heart rate's 124.
Okay. We'll go ahead and TKO that rate down. What's her pain level on a 10 scale?
Well, the pain got better after that medication.
I bet it did. That's the goal.
Give her more.
So what are you doing?
Pain-free?
Taking her to the local critical access hospital? Are you calling Mandy? What's your plan here?
Where's our location?
You are 45 minutes from the hospital, but they have no capabilities for anything.
I'm going to come to UC Health.
All right, so you're gonna call Mandy.
Yes. And we can do, is she on a helicopter or critical care unit?
She's on whatever you like. She's on a helicopter.
Okay. So we'll do an intercept, but we will head that direction when that helicopter gets on the ground before and ahead of us. We'll do that transition there.
Right.
Is her meditation still decent? And
She
I
is
still
still,
have pressure 120/68 post my nitro
that's
and
same.
pain-free. Okay.
Yep. And Mandy is on scene.
Hello, Miss Mandy. How are you?
Hi, good. How are you?
Good. I have a 54-year-old female. She has an inferior with posterior involvement MI. This started about 30 minutes prior to our arrival. She was walking her pet when this happened, and she was diaphoretic, experienced that chest pain. First blood pressure was 132/70. We're now, after a nitro, we did have a line. We'll get a secondary line for you as well. Dropped it to 70. And then we're back at 120/68. Pulse rate has stayed very consistent at 126 to 124. We're sitting at 96%. And we've given her approximately 500 cc's, maintaining appropriately, and she's pain-free now. No medical history, no medication, and no allergies to any medicine. She's also had 324 of aspirin on board.
And you said just one nitro?
Correct.
Okay. All
Took the
right.
pressure down to 70 and we're back to 120 post fluid.
120. All right. Let's go ahead and reassess. Let's make sure that I'm going to listen to lung sounds. I want to get another blood pressure. Are we still currently at a 120/70?
You are, and her lung sounds are clear.
70. All right. All right. Hi, Betsy. My name is Mandy. How are you?
Great.
Great. All right. Let's talk about that chest pain. How is your pain right now? It was at a 5 out of 10. Do you still have it at a 5 out of 10, or has it gone up or down?
Coming back a little bit, maybe 2 out of 10 right now.
A 2 out of 10 right now. Okay. And I'm just going to ask a couple of the same questions. Is it radiating anywhere? Do you feel it in your jaw, your neck, your back?
Nope, just the chest.
Okay. 30 minutes ago, you don't take any medications. We've got some fluid for you. And how do you feel? Have you ever ridden in a helicopter before?
No, but I'm excited about it.
All right. This is going to be a nice, easy flight. It's going to be about 18 minutes to University Hospital. And they're going to take great care of you. So do you have any questions right now while I get some things going?
Are you gonna do anything else while in flight or just?
Oh, no, I'm not going yet. I just want to talk to the patient real quick and just see if her pain has changed, if it had radiated, anything like that.
Yes, sorry. The patient was asking, are we gonna do anything else? Or are we gonna wait until we get to the hospital?
Yeah, I'm going to do a couple things for you. With that pain, that chest pain, I'm going to consider blood pressure is good. if I carry something like unfractionated heparin, I might give a bolus of that so we can get that started. This is somebody that's going to be going directly to a cath lab for PCI. So 2 lines is going to be important. Some fluid, definitely. If this is a posterior involvement, it has the chance to tank. So we've got plenty of fluids for resuscitation. If for some reason pressure continues to tank or get worse, then I could consider more fluid resuscitation or have some sort of pressor ready kind of to supplement, since it's only about an 18-minute flight. That would look like probably a push dose pressor, something just to get good perfusion.
Right.
So pain wise, we're at a 2 out of 10. And if that's manageable for her, then I'm okay with keeping her at a 2 out of 10 because I don't want to mess with her pressure a whole lot if I don't need to. We've got fluid oxygen. We've got a 12 lead. I'll probably take a little bit of blood so we can get some blood samples there so that we can run if they haven't already been collected.
Great. You've arrived at the hospital. It was a really quick flight.
Oh, that's boring. All right.
Don't
Hi.
worry, Mandy, it's just case 1, I'm sure. Hi, Mandy, it's good to see you. What you got?
Hi, Dr. Wright. This is Betsy. She's a 54-year-old female. She comes in from home complaining of chest pain. It turns out that she has a pretty substantial inferior wall MI with posterior involvement. This started approximately 30 minutes ago. She started to feel a little lightheaded, very weak, and complained of about a 5 out of 10 chest pain, non-radiating. Sat down, didn't get any better, called EMS. She did get 324 of aspirin and 1 spray of nitro, which dropped her pressure down to 70/40. Started some fluid about 500 cc's later. That got her back up to the 120s. She's currently at a 2 out of 10 for pain. And her last blood pressure is, again, 120/70. We've got a heart rate of 126 on the monitor, normal sinus tachycardia. We've got 4 liters on a nasal cannula, and she's sitting at 96% on room air. I didn't need to give her anything in flight, just maintained her fluids. She's got 2 lines for you bilaterally, and she has no history of any cardiac issues, no other pertinent medical history. She does not take any medications on a daily basis, and she's not allergic to any medications. Do you have any questions?
No, thank you very much.
Okay.
All right. Hi, Betsy. I'm Dr. Wright. I'm here with our cardiology team who will be helping me because we called the pre-hospital cardiac alert in flight. So we were able to get them mobilized and they're getting the cath lab ready. How are you feeling?
It's like a 4 out of 10 now. It's creeping back up.
Okay, well, I know you've had a lot of these done, but we're going to go ahead and repeat an EKG, see if there's any changes from when you were en route.
Looks the same.
Looks about the same. All right, Betsy, do you understand what we're worried about and what we think is going on right now?
No, I don't know. You guys are using all this medical jargon. I don't really.
I hear you. So, the heart has to get blood flow. And what we're concerned about is there might be an artery in your heart or a blood vessel in your heart that's making it so that part of your heart is not getting enough oxygen. And when that happens, it can make you feel uncomfortable like you're feeling. And it can also make it so that the muscle part of your heart starts to not be able to work in the way that we want it to. The fluids are going to be helping, but ultimately what we need to do is get you to the specialty care where they can do a what's called a cardiac catheterization. They're going to squirt some dye into your heart and see if there are any blocked arteries that they need to open up.
Okay.
Just a couple other really important questions we ask anybody that's going to the cath lab. Do you smoke cigarettes at all?
Yeah.
Yeah. Okay. And how many packs per day?
Like 2.
2 packs a day. Okay. And any family history of major medical problems that we should be aware of?
I think my dad died of a heart attack when he was like 45, maybe.
Okay. Okay. And is there anybody at home that you want us to call that you would want us to have listed as an emergency contact for the process that you're about to go through?
No, Mittens doesn't have a phone, so I think.
Okay. So Betsy, I know a lot has happened since you first called 911, which is a great thing that you did. And I know there's a lot going on right now, but I promise we're going to take really good care of you. Okay. Do you have any questions for us?
Oh,
Okay, well, we've got 2 large bore IVs. Our airway's intact. Our cath lab team is here. She's already gotten aspirin. We're not going to give any more nitro. We're going to give her a bolus of heparin, 4,000 units. We'll start her heparin drip. The other thing we need to make sure of is that this isn't a dissection, because we do worry about certain types of EKG patterns that could be dissection. She doesn't have the hemodynamics consistent with it. The description of her pain isn't consistent with it. We'll shoot a quick chest x-ray to make sure she doesn't have a big wide mediastinum, and then we'll go ahead and get her on up to the cath lab.
Love it.
Okay.
You guys nailed it. You hit all the check boxes. The only 2 things, no one put pads on the patient or verbalize putting pads on the patient. And so that's one of the things, and we can talk a bit more about that. And then the only other thing was maybe an antiemetic with all that nausea from the, which is not a life-saving thing, but yeah. So I will do my spiel and then I'll have these guys weigh in. So basically, for everyone listening in, this was a posterior myocardial infarction, right? These, for my ALS folks especially, really tend to be overlooked. They don't really have the, like, the STEMI elevation. They don't conform to the paradigm that we're usually trained to look for in the pre-hospital realm. We don't usually see, deep pathologic Q waves. We don't see the changes that we really look for. And so we can overlook it frequently. You guys didn't. You totally, absolutely nailed it. We kind of shifted the paradigm from, to STEMI versus NSTEMI. And so that's kind of why we missed the posterior ones, because they don't produce that beautiful STEMI on the regular 12 lead. And so that's why we kind of do the posterior, have to have high suspicion, I should say, high clinical suspicion to do a posterior or a right-sided, depending on, kind of where the elevations and everything else is. The posterior EKG, for everyone who has maybe never done one before, or wants to kind of review, is basically taking leads 4, 5, 6 and putting them on the back, kind of like this. And so on a regular 12 lead, when you're looking at it, 7, 8, 9, replace 4, 5, 6, and it gets you a little bit of a better look at the backside of the heart. That's all my big pearls. I'll have you guys jump in with anything else.
I'll jump in with a few things. One, I thought the handoffs were really great. Transitions of care. They were succinct and to the point, and really only the pertinent things were transitioned. And so I think that was well done between the levels of providers. As Dr. Farkas mentioned, these patients are preload dependent. So the reason that we get a little shaky about giving nitro is that it's that right side of the heart, that posterior part of the heart, that if we give nitro and it causes all the blood vessels to dilate, then you're not getting as much blood into the heart. And these patients, because of the anatomy, are really depending on that blood coming into the heart. So that's why we say fluids. The old paradigm of never giving nitro to a right-sided MI has actually kind of been debunked. I would just say you can give it, and Ryan was going to call for some liability sharing there. But you want to have IVs, which he said he had to make sure he had a line before he gave it, and he was ready to give fluid. So 2 large bore IVs if you're going to do that. The reality, though, is that nitro doesn't actually improve mortality in our STEMI and NSTEMI patients. It can help pain, but the only thing that actually decreases mortality in these patients from a statistical significance is aspirin. So if you're going to give nothing else, just give people aspirin. And then, I don't know, we could wax poetic for a hot minute on destination. So you could drive 5 minutes to critical access and this patient would get lytics and then probably get flown out, versus flying from scene to a cath capable facility. I would love to hear people's thoughts on what they would choose and why. I don't know that there's a great right answer here. Every time it's this, you should do this. I will start by saying the patient was pretty stable, minus the intervention that Ryan did that caused her to nearly die. But just kidding, Ryan, you did great. It's the right choice. And so I think the additional distance and getting her to that final cath capable facility is very reasonable. But I don't know if anyone else wants to weigh in on that, or we can talk about that at the end of this.
And I think it really does, right? It depends on your system and what your hospitals are comfortable with and what you've already set up ahead of time, right? Like some places are going to be like, nope, you're going to fly out every STEMI because it's going to take us 7 hours to get them accepted to a different facility. That's also something you have to weigh in. Similar with stroke, right? When it's kind of that time dependent emergencies, you kind of have to weigh am I going to delay their care by taking them to the local hospital because then they have to go through the acceptance process and that can take a long time, versus is it really just going to be faster to fly them out? And I've talked to a couple of my agencies about this on stroke specifically. That's kind of like always a really hard act to balance, is the only thing I have to weigh in on there.
And from the chat, and then we should have the other folks pipe in, the other providers too. I just want to shout out and completely agree that that solid BLS interview and assessment put this team like ready and ahead of the curve. So Ryan came in with a great story and a great, like, was in a position to immediately move into his ALS role, which is what Jason recognized he needed. So shout out, great work. Somebody else talk.
Well, thank you. The only thing, if I could self-critique, we didn't find out about the smoking and family history until she was already at the getting ready to go to the cath lab. So, I mean, that was where I kind of I flubbed that one. But other than that, I think it went really well. Great job to everyone on the team.
And I will say that's a very important risk factors for ACS. Absolutely. Is that going to affect the care you provide to the patient? Not really, right? So that's not a big miss. Mr. Scherschel.
I'll jump in. First off, congrats to the crew, because these are not easy to do, and verbalizing your patient condition and skin color and tone and all that thing is complicated. And I think you did a really nice job. So good job. As far as destinations go, I think ultimately it's always gray. Like hindsight's always 20/20, but what to do in any given case is very complicated. And there is no right or wrong answer. I think definitive care is very important. But there's also 100 things that can get in the way of, oh, we're just going to call a helicopter and rendezvous with them in 20 minutes. And they have an 18-minute flight to definitive care. So critical access is always an option. And I think you just have to weigh that on a case-by-case basis and know that it's a really complex and complicated decision. So that's my 2 cents.
I'll jump in and say that it's a good thing to run through your head to see, is it going to be more beneficial to go to the critical access center where I'm going to have more hands to be able to help get me a line or 2, and somebody else can give the aspirin and another person can get a 12 lead? Is that going to be beneficial for speeding the process up while whoever ALS or critical care or whatever is getting to me? So utilization of resources can be sometimes very helpful if you are on a limited crew and you don't have a lot of people for it.
Love it. And then, yeah, Kevin pointed out too, there's a couple people in the chat. We highlighted the BLS interview and then kind of some people weighing in on what they would do. Deb out in Idalia would be calling for flight, but talking to the local hospital. Mickey would be going to the local hospital and the patient would be transferred. So obviously a wide variety there. And then Kevin pointed out the weather conundrum, right? So if you're flying and they can't fly, well, then you don't really have any other options. And then you can always rendezvous as well, which you guys did. All right. Anyone else? Anyone from the audience want to weigh in? Anything else before we go on to our second case? Beautiful. All right. Are you guys ready? Okay. So your second case, you are dispatched to Cobblestone Inn. It's around 1600. And you are called for a 3-year-old who is not acting right. Her parents. I can see everyone just clam up a little when we said 3-year-old. On the way, you notice that it's cold outside, but the weather is clear, light winds. You're pretty close to the hospital again. You're about 5 minutes away from the critical access hospital.
Excellent. Okay.
Looks good.
All right. Any further dispatch information?
So all you got.
Okay. Sex of the patient?
I'm sorry.
Not whether they have, but sex, gender.
Oh, got it. I just didn't hear that. 3-year-old male patient.
Male, that helps. Okay. Chief complaint is just not acting right. Okay. All right. Just so happens, on a real quick sidebar, I'm also working at the Cobblestone here in Ray, so it's kind of an interesting choice. So I know the place very well. All right. We are on scene. Gonna meet with the front desk staff, see if I can find out what room they're in. Do you have a directions to the room?
Yep. Just the room right down the hall.
Oh, okay. Yes, they're probably like 105, the one with the jacuzzi tub, I'm sure. All right. I'm gonna go ahead and hi. Parents' names.
Hi. Yeah.
Parent.
We're Bob and Beth.
Bob and Beth. Okay, sounds good. Who I'll be speaking to mostly, or just irrational, frantic from both?
Sure. Yeah.
Okay,
Both.
perfect. So what's the child's name?
Case.
Case. Okay, perfect. Perfect. That makes total sense. Can you kind of tell me what's going on, Bob, Beth? Either one of you go ahead and pipe up.
Yeah, we're visiting grandma. Just
Okay.
up the way to Salt Lake City is actually where you're trying to get to. And yesterday he got into his grandma's purse and had there was an empty pill bottle. And so we weren't really sure what was in it. We took him to the emergency department in Nebraska last night. He was there for a couple hours. He was just observed and then he was discharged. And so, we decided to stop in Ray for the night, which is where you are. And yeah, he just started really acting bizarrely. He was really tired this morning. He didn't eat breakfast. He's been more fussy than usual. And now he's just, I don't know, he's just not acting like himself.
Okay. What's the patient currently doing?
He is just kind of laying there. He's barely interactive.
Laying on a bed, on the floor, on a car seat, couch. You must have bear with him. Okay. All right. I'm gonna go ahead and get some vitals real quick.
Okay.
Put a child size BP, infant BP on there. Gonna get a pulse ox. We'll stick on sticky pulse ox thingy. What are my vitals?
His heart rate is 64.
Okay.
His blood pressure is 78/42. He's breathing 4 times a minute and setting 91% on room air.
What were the respirations again? I'm sorry.
34.
Ooh, that's breathing kind of quickly. All right. I'm going to go ahead and start some oxygen for this little guy. We're going to do high flow pediatric nasal. No, let's go ahead and do a non-rebreather. I'm going to start him at 15 liters, just to kind of get the party started. All right. What is his GCS? Is he responsive? Or is he when I kind of tickle him a little bit?
Yeah, he'll awaken when you kind of hit him and open his eyes, but he's not really doing much.
Okay. All right. But you say he's crying or not really crying?
No, he's just sitting there.
Okay. Sorry about that.
Ventilation.
I just had to do some quick. Okay.
Right. There was a clarifying in the question in the chat. It is 34 times a minute.
Okay. Perfect.
Sorry.
We've got a GCS of about 11. Okay. What color is the child? Do we have any ashiness or any bluing around the lips or the hands, feet?
He's pretty pale, a little diaphoretic. You notice his hands and feet are pretty cool to the touch.
Okay. I should have mentioned this a while ago. I'm going to go ahead and request ALS intervention because the child is possibly has a drug medication exposure. I'm really surprised that ED and that we're having some kind of revisitation of the problems if he's already been to the ED. What was the results at the ED? What did they say?
So he was fine then. Like when we took him, he wasn't acting abnormally. We just weren't sure if he had like taken anything, and they watched him. And they just sent us home. But like, he's just, that was last night, and this morning is when he started acting a little funny.
Okay. You didn't get a look at what was the label on the pills, or did Grandma have any idea what was in the purse?
No, so grandma only uses this bottle when she's out and about. So she just kind of put all her meds in it. But she wasn't sure if there was anything in it or not.
Okay, that's really helpful. Okay. All right. I'm going to go and do a real quick physical assessment of the patient. Just see, do I feel anything, see anything?
No evidence of trauma.
Okay.
His airway is patent. Just,
Okay. Does he have any allergies to any meds that you're aware of? Any medical conditions you're aware of?
not that we know of.
Okay. When was the last time he did eat anything or drink anything?
Breakfast, but it was like not a lot.
Didn't really. Okay. I'm going to look to his eyes real quick. I'm going to open his eye, and what do I see there?
They're equal and reactive to light.
Okay. All right. All right. So, how has the oxygen helped? We're on 15 liters of that non-rebreather.
He's on 95%.
Okay, so it's 95. All right. Anything? All right. Really like my ALS to be here, but we'll just go ahead and kind of.
Gonna say your medic is right outside. Anything else? Any last minute things before your medic shows up?
Let's see here. Let's see here. Pardon? All right, I'm going to go ahead and I think I'll go ahead and get an IV real quick if I can.
Yeah, you can do an IV.
Okay, I've got an IV started. I got a 22 in that arm, that left arm.
All right, ALS is there. Ryan has arrived.
All right, hey Ryan, thanks for coming down. We've got Bob and Beth here. Their 3-year-old son here. He's basically just not acting right. He's lethargic. He has no appetite. He's drowsy. GCS of 11. He's just really not as responsive as we'd like him to be. First set of vitals was 78/42. Respirations 34. Had a heart rate of 64. He was set in 91 on room air, so we went in and started with a non-rebreather. He's now set in 95. Basically, the situation is that they're on their way to Salt Lake City. They were visiting Grandma last night in Nebraska, and got into a little case here. Got into Grandma's purse where she keeps, just a mixed bag of pills for when she's out and about. There was nothing in the pill vial that they saw. They're not sure if he took anything or not. So they did take him to the ED last night. They did observe him. Really didn't do much for him, doesn't sound like, but they discharged him for observation. They made it here, and he's just really not acting right this morning. We do have a 22 gauge IV started in the right arm.
22 in the right arm.
Yes.
That's what I heard. So kind of what we'll do is just start working from the ground up. Basically with the vital signs, we're looking at a low pulse, a low blood pressure, and a high respiratory rate for that age of pediatric patient. If you would, Jason, on hand Tevi or whatever you're using for Broslow tape, pull up everything for a 3-year-old that we're going to need for this call. And then in my mind, just to kind of get everybody on the same page, I'm looking at polypharm overdose. We're going to also have in the back of my mind sugar seizure, and then non-accidental trauma is always kind of in a case like this. So we're going to start with sugar, just rule that out. I don't suspect that is the case, but what is our blood sugar?
GL is 204.
So a little high, but not our problem.
And to
Where
add
patient
to
presented.
beginning, there's no immediate signs or concerns for abuse or neglect. There's nothing that gets your spidey senses tingling on scene.
Okay. And then no seizure activity from the kiddo, no incontinence, no bite on the tongue.
None of that.
Has he been witnessed pretty much since for the past couple hours?
Yeah, since he woke up this morning, which was about 8 hours ago, we've kept a close eye on him, but
So when we're looking at the overdose, kind of what I'm looking at is where we were. So let's get actually the history on grandmother's medical problems and try to start to narrow this box a little bit on the poly farm.
all right. Grandma doesn't really know her medical history, but she was able to text pictures of all the bottles to the Bob and Beth, or whatever I said their names were. So she has a couple meds. She has ibuprofen 200 milligrams, has Tylenol 500 milligrams, has diltiazem 240 milligrams extended release. Vitamin D, she takes 1,000 IUs of that, and then aspirin 81 milligram. And she really does not know what was in that bottle, doesn't know which of the things she packed for the day. She can't remember which one she took in the morning and what she needed to take at night still. So any of them could have been there. But she says she usually keeps one of each. So it's unlikely to have a whole bunch of either one of them. It's usually just one at a time.
Okay.
What at a time, I should
The
say.
two that kind of concern me the most are the ditalazam and the Tylenol, for two very different reasons. So let's go ahead and do an EKG and see what we've got coming up.
EKG, I will tell it to you because I don't have an example, but it is sinus bradycardia, a little bit of a prolonged QT.
Okay. And the fact that it was extended release is a little concerning as well, which could be the explanation of what's going on here. So we'll go ahead with a line and oxygen coming up. We'll go ahead and start our transport now.
Are you going to rendezvous with Mandy just to make sure she plays too?
Yes, eventually, of course. As long as the helicopter is cold in between me and the hospital,
Okay.
we would gladly hand it to her.
Okay. Yeah, let's say Mandy is able to meet you very quickly.
Oh,
Mandy.
you don't want me. Okay.
Oh no, if you want to keep going, keep going.
Yeah, so as we look at this, kind of what's coming in, glucagon definitely is something that's potentially used for this. Basically, we need to get that to release. That's obviously not within our scope, but we can certainly make that phone call. And that's what we have in our toolbox for this particular kiddo. And then you've also got calcium as well.
And then what, all right, let's say Mandy just landed, and you can, let's say, Mandy's landing now, just in a couple minutes, but the heart rate you're noticing is dropping a little bit. It's in like the 50s now.
So we'll go with a vasopressor on this particular kiddo.
What are you going to use?
Epi.
Yeah. Okay, great. You've started Epi and Mandy has arrived.
Okay. So real quick, just before I start giving a report on this, I'm just going to cue Mandy in that we're going to need calcium and some glucagon for calcium channel blocker flavor of overdose, kind of that treatment branch. And then I'll go ahead and give her report so she can kind of work and listen at the same time. So Mandy, we've got a 3-year-old male. Yesterday, basically got into grandmother's purse. She took ditalazam and Tylenol. Were in that were the two of the nasties. And then you've got a blood pressure of 78/42. Initial pulse rate of 64, which dropped to 50, which necessitated the epi drip that we did. 34 on respirers. Initial sat was 91%. We're currently at 95 with oxygen. Glasgow was 11. Blood sugar is 204. You've got a 22 on the right AC. Anything that you need from us? We'll get a second line for you while you're catching up with us. So we'll go for the other AC.
Okay, let's get
Same
a
page.
second line going. We're in the field. Let's go on a 3-year-old at a row. Let's go to weight of 14 kilos. Does that sound appropriate for that kid size?
Yeah, I was going 15, just
15?
off a hand heavy.
Easier math.
Yep.
Let's do 15 kilos for math. Okay, I want to get a full set of vitals and I want to just take one more quick peek. It's in sinus Brady. There's no other shade being thrown. There's a kind of a questionable QT. It's maybe looking long, but maybe prolonged. Is that right?
Yeah, so
Yeah.
on repeat set of vitals, heart rate was in the 50s, I think I said, like low 50s. Now after the epi that Ryan started, it's like 60. It is just sinus on the monitor. And his blood pressure is 70 over PELP.
Okay. Okay, so epi, we did push dose or dirty epi drip?
I don't know, what did we do, Ryan?
We're going push dose.
Awesome. Okay. Has push dose helped his
It did.
70
Yeah.
and
So
blood pressure currently?
So it did help for a bit. Now he is looking a little crummier. Heart rate is now in the 50s, again, low 50s. Blood pressure is kind of dropping, maybe like a 68 systolic over PELP. And he's looking a little bit less responsive.
Pulses,
He does have pulses still.
his rate?
51.
Okay. Is he opening his eyes? Is he reacting? Is he looking at me? Did he flinch when the second IV or the first IV were started?
He is much less responsive. He opened his eyes with the IV, but not doing much else.
Okay. Well, we're definitely going to need to do some. We're going to do a presser here. We're going to do a presser, calcium and epi, I think
Okay.
is what I would like to do. So epi first, right? We want to get that heart rate up and we want to get that blood pressure up, getting perfused. So we're going to start on an epi drip.
Great.
That's going to be weight-based. We'll start that, set that up. We can still have push dose if we need to in between. If we need to bump that up, I want a map of at least 60. I want to start some calcium, which I should have, and give some calcium to see if we could help with that, which will be en route. Do I need to airway? Are we still breathing rapidly but maintaining our own air? Are we maintaining our airway?
His O2 sat becomes unreadable and he does not look like he's still maintaining his airway.
Perfect. Okay. Then we're gonna have to kind of stay here for a minute because if we need to intubate him, we're gonna need to make sure that we have him a little bit better resuscitated. So getting the pressure up, working on a little bit of fluids at the same time. With our epi, I'm gonna prepare my supplies. I'm gonna intubate him. So I can RSI him if he does have a gag reflex. If he does not, which I'm guessing he is. So I'm going to go ahead and RSI him. With that, we're going to need to make sure and get his oxygen sats up as high as we can get him and do pre-oxygenation or apneic ox. So I'll get that up at least above 90 before I consider that. So we've got epi, we're getting calcium, we're pre-oxygenating, got fluids. And then we're gonna make sure, hey, sorry. We're gonna intubate him and get him on, I don't have any labs or anything like that, but that rapid rate, I'm gonna guess that we're gonna need to keep it a little bit higher than just bottoming him down to about 21 for age 2. If he becomes acidotic or he has a metabolic acidosis going on, then he's gonna have a higher respiratory rate. So if I put him on bagging him, or if I vent him down, then that is going to make things worse. So I'll keep his rate. I'm going to recheck his sugar. I'm going to fly him to a children's hospital.
Great. So you do all of these things. His sugar is still, I don't know, 190, let's say. After your epi and calcium and fluids, and you got him to a better heart rate of in the 70s, blood pressure was, let's say, in the 80s systolic. So you intubated him and managed his airway appropriately. His last set of vital signs, as you're handing off to our pediatric emergency medicine specialist, Dr. Angela Wright, who I think is cursing me now for making her do a Pete's case.
She said she was going to a children's hospital. I don't work at children's. I work across the street, so someone else is going to tap in on this one.
They got lost. They went to the wrong facility accidentally.
I'm so silly me. I went to university instead of children's.
Dr. Wright, I don't know if you got the memo, but children's closed their helipad, so they're doing.
Oh, okay. Well, and I am, but technically a board certified emergency physician, so I am credentialed and very capable of taking care of pediatric patients.
His last set of vital signs, right as about your to give hand off, is heart rate 72, blood pressure is 80/57. He's breathing 32 times a minute because that's what you set it at, and then is setting 96% on his oxygen.
All right. All right. Hi, Dr. Wright.
Hi.
Hi, this is
hospital.
Yeah, wow. It's crazy seeing you here. This is Chase. Chase is a 3-year-old male who was hanging out with mom and grandma. Sounds like he potentially got into a suspected diltiazem potentially, or Tylenol, which is in a big list, or in a list of medications. We're not entirely sure what he has ingested. However, he was symptomatic bradycardic, he was hypotensive, and his mentation certainly decreased at a rate of 32 on arrival of EMS. So they have bilateral 22 gauge IVs. We have since given fluid, started him on some epi push dose initially, then went to an epi drip, and this is what my epi drip is running at currently. We have also given some calcium for this suspected calcium channel overdose. And we have given some fluids. During the course of this, his blood pressure kind of waxed and waned a little bit, helped on epi, then it kind of went down. So with this, we did some resuscitation, and it opted with overall presentation to intubate. So we have a 5.0 tube this deep. We have him at a rate of 32, keeping it where he was, and these are his vent settings. His current set of vital signs now, we've got a heart rate of 72. I did see on his EKG that he potentially has a prolonged QT interval, so that might need to be rechecked. Our current blood pressure is 80/57. We have him intubated on a vent at 32 times a minute. His SAT is 96% on 100% FiO2 and 5 of PEEP. Do you have any questions for me?
Do we have any idea what time he may have ingested this medication, and if it was regular release or extended release?
Yes, we are suspecting this could be an extended release tablet of diltiazem. And as of right now, with relatively quick transports, we don't have an exact time of ingestion, but we have not had any noted vomiting. And it has been at least several hours.
Okay, sounds good. Thank you. And you said you gave him epi and calcium
And fluids. We have not done anything else.
Okay, great, thanks. So we already have an airway intact. I'm gonna confirm airway placement, probably with a quick video laryngoscopy and waveform capnography. I will check bilateral breath sounds, and for circulation, we'll check pulses, and he already has the 2 IVs that are good for his size. So doing a quick primary survey and verifying kind of all of those aspects. He's gotten a lot of the major treatment for this so far, as hemodynamics certainly seem to have improved, although they're not quite where we want them to be. So I'm going to repeat an EKG. I'm going to shoot a chest x-ray. I'm gonna talk to pharmacy and try to get some high dose insulin therapy. So that's the other thing we can do for calcium channel blockers. He was hyperglycemic, but with the high doses we have to use, I would start a dextrose infusion as well. So we'll be doing high dose insulin therapy with high dose dextrose. And he's gotten the rest of the medical interventions that he can get. I would be talking to toxicology and then thinking through the other meds, Tylenol, 500 milligrams for a kid of his size. We'll send a Tylenol level and LFTs to make sure he hasn't taken a liver hit from that. I do worry about aspirin overdose, but in the setting of probably 181 milligram tab, less likely. And certainly the most concerning is the calcium channel blocker. So I will be giving him high dose insulin and glucose therapy in the emergency department, confirming all of his stuff, talking to tox, and admitting him to the ICU.
Beautiful. Your frantic Googling of calcium channel blocker overdose. No, I'm just kidding.
One pill can kill. I know it's on that list.
So I will do my spiel and then let you guys weigh in. Absolutely nailed it. On this case, good job getting grandma's history, right? That's going to be the only way sometimes you're going to get that information. And this was designed to be a case where there are just enough medications to make you go, uh-oh. But really the big culprit here was that calcium channel blocker. Remember calcium channel, or not remember, but calcium channel blockers, beta blockers, glucose is one way you can sometimes tell. Glucose is high in calcium channel blockers, it's low in beta blockers, is one way you can differentiate sometimes between the two if you're not quite sure what's going on. Unintentional poisoning is really common in like the 12 to 36 months age group, right? Because they're just old enough to be walking around and grabbing stuff. And there's, like Dr. Wright said, 1 pill can kill. If you guys Google that, 1 pill can kill pediatric. There's a bunch of medications, diltiazem and other calcium channel blockers being one of them. The potentially lethal dose of diltiazem for peds is 15 mg per kg. So it kind of does not take that much. And then those extended release formulations can really cause a delay in symptoms up to 16 to 24 hours post-ingestion, right? So this kid got into the purse last night, took some drugs, was at the ER that night, but he was fine, right? They didn't do anything wrong. He was just asymptomatic and hadn't kicked in yet. And so 16 to 24 hours later, he starts to become more sick. The treatment, well, let me back up. So obviously calcium channel blocker overdose is going to cause significant bradycardia, hypotension. You guys identified that right away on his initial vital signs. You might see some conduction disturbances. You might see some weird rhythms. And then the way they work is that they reduce the insulin release from the pancreas. And that is how you also see some hyperglycemia as well. Your treatment is going to be ABCs, and then establishing and maintaining an airway. You're going to give them a bunch of oxygen. IV access and fluids. You know, the atropine, you can think about it for bradycardia, but it's probably not going to work in this case, right? Because your conduction is all messed up. Oh, when I see a question, yeah. Atropine pacemaker be on the table. Atropine, you can try it, absolutely. It's probably not going to work. Pacing, you can absolutely consider that as well. But peds patients tend to respond really well to epinephrine for bradycardia, more so than adult patients, which you might elect more to pace. So good question, Justin. Then you're going to do some type of inotrope or vasopressor support, right? So epinephrine is going to be your first thing. If this patient was still profoundly hypotensive, you would do a second line, right? So whatever the critical care medic has, but norepinephrine, vasopressin, whatever pressor you have as a second line. Calcium is a temporizing agent, so excellent. You can do glucagon as well. And then in hospital is when you're going to do that high dose insulin. If they present really late, they have a high lactate and they have metabolic acidosis. So as you identified, Mandy, you are making sure that you're not slowing down their respiratory rate to breathe off all of that CO2. I'm so proud. You guys are so smart. I work with such smart people. What other pearls, comments, questions, concerns do you guys have?
The only thing that kind of messed with me a little bit was the fact that he was checked out at the ED and everything was fine. And then the extended release, I didn't think about it, the medication, that extended release. But I'm glad that those above me were able to catch that and think of that. So thank you, guys.
All right. Anything, how long after do you wait for all the other drugs? That's a good question. I don't know if I know that. You mean like how long until it, like you're waiting for it to kick in, or what's your question, Kevin?
I think they're going for the action time of the calcium and an action time of the glucagon.
Oh, I don't know that off the top of my head.
That's what I was thinking. You given all the other and you weren't having any much changes and the heart rate wasn't going up, you given all the other stuff. I mean, are you waiting like 20 to 30 minutes after giving all those drugs before that? I mean, I know you got to do the insulin. I know you got to do the calcium. I know all the other part of it, but I mean, when is that magic point other than the patient's not getting any better and crumping on you? What's the time frame should you look at? Or, I mean, you think of all that stuff. When do you do it?
Yeah. I mean, I will give my answer and then have you guys weigh in. But I mean, I would say, the epinephrine is going to be probably your first move with the patient that's bradycardic and hypotensive to kind of temporize, to give that inotropy, chronotropy, etc. I don't know about the calcium and everything else. I don't know how quickly it kicks in. I imagine it's similar to when we use it for other things like hyperkalemia, and it does tend to be pretty quick, but somebody else who's smarter than me can maybe answer that.
I'm not smarter than you, but my approach to these are the completely arbitrary number that I will throw at you is like 3 to 5 minutes. If these interventions are going to work, they're going to demonstrate that they're working. So if you see a response with epi, go up on epi if you need more of a response, and then you're going to see a little bit of change. In calcium, remember the mechanism that it's working. This is a calcium channel blocker, so you have to overpower this medication on that calcium receptor. So it's going to be dose dependent and it might take a little bit longer as well. But I would say if you've done all of these things, epi and all of that, and you still have a hemodynamically unstable kid after 5 minutes to 10 minutes, you're going down the path of electricity. I also tend to be like a little more aggressive than other people, so you could probably wait a little bit. All right, do we have time for one more?
We sure do.
Great. I feel like I should wear noise canceling headphones for the first part of it, and then I have to do everything based on Mandy's handoff.
That would be more realistic, but I decided to be nice to you guys.
I appreciate that.
All right, so your next and final case is you are called to a male who fell. That's what the dispatch says. And then as you're kind of getting on the way, you notice that the address you're going to is about 20 minutes from where you are and about 20 minutes from the nearest hospital as well. Dispatch says it's a 68-year-old male who was found down on the ground by family. They think he fell off the bed of his pickup truck is what we're going for.
All right, looks like I have driven 20 minutes and I'm on scene. What do I see? How many people are on scene? Where is the gentleman now? Is he on the ground? Is he?
Yeah. All great questions.
Mhm.
When you first walk up, the house is nice. There's a couple family members on scene. Let's say his wife and their son. You see him unconscious on the ground. He what you get, yeah, that's all you get.
Okay. All right. Hi, I'm Jason with Ray Ambulance. Sorry we're having to meet like this, but I'm more than willing to try and help out, and we'll see if we can take care of your husband here. What's your husband's name?
Name is Kyle.
Kyle. All right. Well, hey, Kyle. Kyle, can you hear me? Anything? Shaking him, tapping on the chest, anything? Any
That's not,
response?
no
Kyle.
response.
All right. Hey, what can you tell me about Kyle? Does he have any medical issues, or do you know what he was doing when he was before he fell? Where were
Yeah,
you at when it happened?
yeah. He has a heartburn, I think, and some hypertension, just
Okay.
regular stuff. We went to the grocery store. And when we left, he was working on getting some mulch from his pickup truck and putting it in his garden. And then when we came back, we just found him on the ground, the tailgate's open. We're not really sure what happened, but look how nice the garden looks, right? You did a really good
It looks
job.
great. Your peppers are looking good. They could probably use a little bit of calcium though. They're dropping some blossoms there, it looks like. But that's beside the point. Um, Before we get too involved, I'm going to actually get a little bit more hands on the patient real quick. I'm going to go ahead and do a real quick trauma assessment, feeling neck, head, arms, any abnormal body position, anything that I see.
Great questions. His head and neck, he has no step-offs or deformities.
Good.
He's laying down on the ground.
What is his position? Is he face down, face up, on
He
his
is,
back? Okay. On his back, okay.
yeah, he fell backwards. Yep.
No. All right. Any bleeding I need to worry about? Okay.
Maybe blood in the back of the head, but nothing crazy.
Okay. All right. Blood in the back of the head. All right. All right. I'm going to go ahead and get a C color for this gentleman because because of the head strike. Excuse me, Miss Wife. Is he on any blood thinners currently? Just
No blood.
aware? No blood thinners. Okay. All right. Moving further down, do we have any chest trauma? Any? You said back was fine, spine was fine.
Back was fine. Spine was fine.
Okay.
Trauma, abdomen, atraumatic also.
Okay. All right. All right. I'm gonna go ahead and get some lung sounds real quick as well.
He's breathing pretty slow and
Okay.
pretty shallow, but they're clear.
Okay. And what was my rate on that?
4.
Oh, okay. 4. All right. I'm going to go ahead and get him hooked up to the monitor real quick. Get a blood pressure.
Blood pressure is 185 over 112.
85 over 112. I believe this gentleman's going to need some respiratory assistance. So I'm going to get out my BVM. I'm going to hook up the oxygen to it. What's his pulse ox?
His pulse ox is 84% on Romer.
All right. Yeah, that's not good. All right. We're going to go ahead and start bagging him at a rate of about 6 breaths a minute. No, 12 breaths a minute. Sorry, every 6 seconds. Sorry. What's our heart rate?
Heart rate is 40.
40. Okay. Gosh, I should have mentioned this. I did. It was before I got on scene. I was going to go and request ALS intervention as well.
Oh, okay. Yeah. Ryan got the page. Yeah.
Good. I was hoping maybe he was just having some lunch or something like that. All right. So we're bagging, and any improvement for him here?
Yeah, he's easy to bag. Nothing else changes.
Okay. All right. So let's see here. Not really anything makes this any better. Yeah, just. How's the pelvis? Is it stable and everything? I just forgot about that.
Pelvis is stable.
Okay. All right. Well, we're just yeah. I'd say does the family have any other information for me about anything that might have caused this? So no real medical history, you said?
No, just heartburn and hypertension.
Okay. All right.
Yeah, I don't know what happened. He's very independent. He volunteers at the library. I don't know.
That's good. That's good. I don't really like to read. It's not really my thing. Well, gosh, we'll just let's see here. Again, I'd really like my ALS to be here, but I understand it's 20-minute response time. Gosh, we've got a seat collar on. We're not really gonna consider any other. Could get him on a vacuum mattress, but I kind of need some assistance there. Who else do I have with me on my rig? Do you know? Is it just the driver? Or?
You, yeah, you have your local friendly ambulance driver who is
Excellent. He's EMR, you said? Okay, perfect. All right. Oh gosh, let's see here. What else can we do? Just really unconscious still, huh? Gosh. I'm gonna check his eyes real quick. That's one thing I forgot. What's his pupillary response like?
left pupil is blown. The
blown?
right, yep, blown, too big. The right is sluggishly reactive, about 4 millimeters.
Okay. All right. Sounds good. Yeah, might be patient. Yeah. Gosh. Let me check the comment section, see if there's anything. Does this person have a gag reflex intact?
He has a bit of a gag, sure.
Okay, so we won't be able to. This time we will not be inserting an oral airway. I'm going to go ahead and get an IV started. Due to the fact that it is trauma, I'm going to get dual large bore IVs. Actually, I missed. Damn it, I missed on the left. I'm going to go ahead and go up a little bit higher. And yeah, it is secured on the third attempt. So yeah, we do have 2 IVs now. I'm still
Awesome.
practicing.
Ryan drove really fast, so he's
Thank-
here.
Hey Ryan, this is Kyle. As you can see, he's a 68-year-old male. Chief complaint was a mechanical fall. Fell out of the back of the pickup bed is what's believed. He was found down unknown time by the wife and son. He is not doing real well, as you can see. He's GCS of 3, unconscious. He did have respirations of 4 and pulse ox of 84. So we went ahead and started him on 100% oxygen, 15 liters through that BVM, and we are bagging for him, breathing for him, or assisting him with his ventilations about a rate of 12 per minute. His only medical history is hypertension and heartburn. We did get a C-collar on him because of the fall and the head strike. It's not really bleeding too much, but we did have a head strike. He is not on blood thinners this time. His spine was okay. The only other real concerning thing are the eyes. His left pupil is completely blown out, and his right is about 4 millimeters and sluggish. So I'm going to kind of
Excellent.
help you out with anything you know. He does have dual large bore IVs, left and right arm, 18. He has really great veins because he's very active.
Okay. Jason, if you'd continue to manage that airway,
Absolutely.
make sure you've got good rise and fall. Let's get a new oxygen saturation rate.
You are bagging him with oxygen. Hold on.
While you're thinking, I'm going to give this disclosure since we got 2 right and we're on our 3rd. My safe word's pineapple. So we'll continue with the scenario.
His oxygen's better. It's like 92%.
Okay. So with that blood pressure, pulse, respiratory rate, we're going to start in the trauma. I have a little bit of a suspicion at the very end, if we have time, we'll move into clearing a couple of medical things as well. But we're going to start very aggressively with the trauma with the Cushing's triad there. So we're going to be rapid transport with a trauma alert. What's our Glasgow on this patient, Mr. Kyle?
It is not great. It's like, I don't know, 6.
Okay. So we're going to go ahead and intubate Mr. Kyle.
Mr. Kyle has a bit of a gag reflex.
Okay. We'll nasally intubate him.
Well, Mr.
You
Kyle.
can intubate anybody with enough Curlex.
While you're doing all of this, Mr. Kyle starts to have seizure-like activity.
Okay, so we will go ahead and give him some Valium, and we will give him 5 milligrams with one of those IVs.
Valium, Versed?
Versed 2 milligrams. There you go.
I was gonna ask, do they still make that?
How
I'm dating
1994 of
myself.
you.
I am dating.
I just sort of, what year
I
is
will go
it?
2 milligrams of Versed.
Nasal innovation and Valium?
Yes.
God damn it.
No mask pants, Ryan.
I was just getting ready to say we're throwing the mask pants.
Any blood in his ears?
No blood in his ears.
Okay. So we'll redo a head to toe. Let's see if anything has cropped up other than the head with the blown pupil.
Nope, nothing else. And with
Breath
your
sounds.
breath sounds are equal bilaterally.
Okay.
With your treatment of benzos, he has stopped seizing.
Okay. And my new set of vitals.
Heart rate's 36. Blood pressure is 187 over 115. And he's being bagged and is now like 90% on your bagging.
Okay. And let's go end tidal. What do I have for waveform?
Let's say it's 24 with a good waveform with your bagging.
Okay. I'm not 100% convinced that he just fell out of the back of the truck, so let's do a 12 lead. Otherwise, I would not do this, but I'm just not sure that Mr. Kyle fell out just purely for trauma reasons.
I love it. Let me get you the 12 lead.
And we'll check his sugar as well.
Great. Sugar is 76.
Okay. Any medications that he currently takes?
This is your 12 lead real quick if you want to take a look at that. Cool, cool, great.
Cool. Okay.
And then medications he takes are lisinopril and Prilosec.
All right. Mentation, is he still staying subdued?
Yes, he's still subdued.
Okay, we will keep him nice and comfortable that way.
What's your dispo plan? Where's he going?
We're gonna basically do a rendezvous again with Miss Mandy, and he'll go to a level 1 trauma center
All right.
on a trauma alert.
Yeah, Miss Mandy's on the scene.
Oh, hi, Ryan.
Well, hello. We have a 68-year-old male unwitnessed fall out of the back of a pickup. We've ruled out anything medical that is significant. So you're looking at basically Cushing's with a closed head injury. We have pupils, left was blown, the right was sluggish at 4 millimeters. Initial SAT was low at 84, and we're now sitting at 90. He has been nasally intubated, did receive 2 of Versed with a seizure. Glasgow was at 6 and nothing in the ears. All the rest of his physical exam was atraumatic. We have called a trauma alert for you at university. He has history of heartburn and hypertension, meds lisinopril and Prilosec. There are 0 blood thinners that he takes, and you have 2 large bore IVs. Last set of vitals 36 for your pulse, 187 over 115 for BP, sat at 90% with a rate of 24. Or not rated 24. He's being bagged. His capnography is 24. My mistake. Correct.
And he's gotten 2 of Versed, and that's it?
Correct.
Okay.
And his blood sugar was in the low hundreds. 112 or something.
72.
76. 2.
76.
76.
Oh.
Okay, so if I do a sternal rub on him and hi, hello, sir, is he posturing at all?
Maybe you could say he's starting to posture a little bit.
Okay. Fair enough. All right, a couple things here. Is the nasal tube good? Do I have good compliance with it? Do I have good readings? Everything's fantastic. Double check that. We're good to go. Perfect. From there, I would consider definitely some well, I could consider Keppra for seizures. If he has some kind of increased ICP and it's above the tentorium, Keppra will be great for that for seizures. Also, I'm not sure if this is cerebral edema or if this is blood, but there is increased ICP, so we could definitely consider like mannitol or 3%. I would call for that for sure. So I think I'm going to call the doc and ask what she thinks about 3%. Ring ring.
University ED, go ahead.
Hi, Dr. Wright. This is Mandy, and I am here on scene with a 68-year-old male unwitnessed fall from the back of a pickup truck. He initially was unconscious and responsive. He has a GCS of 6. Right now, he has unequal pupils. He has a blown right pupil and a left sluggish pupil at about 4 millimeters. He is nasally intubated.
Nasally intubated?
Nasally intubated. Our on-scene medic got a fantastic nasal tube.
Keep going. Sorry for interrupting.
He did have a witnessed seizure and was given 2 milligrams of Versed, which in that point the seizure did stop, but he's bradycardic, he's hypertensive, and I'd like to give some 3% for his increased ICP. How do you feel about that?
That seems very reasonable to me. Go ahead and give him, do you have mannitol?
I only have, sure, or 3%.
Either one, whichever one you have, but yeah,
It would be
one.
3%.
Give 3%. And how far out do you think you're going to be?
We're gonna be about another 6 or 7 minutes here, and the flight is super fast. We'll be seeing 20 minutes.
Great. Sounds good.
All right. So then I go ahead and give my 3%. I'm gonna make sure and monitor my airway, change him over, put him on the vent. I'm gonna watch that heart rate really closely. I don't necessarily want to do a whole lot to it if I don't have to. I'd rather his pressure come down and then magically his rate come up. So I'm gonna see what the 3% does. He does have an airway that is secured. Just gonna go feel around the back. Do I feel anything on the back of his head? Is there any evidence of crepitus? Is there any big goose egg? Is there?
He has a hematoma with a little bit of an abrasion, but nothing else. But what if his blood pressure, let's say, goes up to 211 over 117?
Oh, woohoo. That's right at, let's see, 2. That's going to be right around the point where it's, I mean, that's real bad. So we need to get that down lower. We need to get that down a lot lower. Bringing down his blood pressure. I mean, if Ryan nasally intubated, can I do some therapeutic bloodletting? Let's see.
We're
So
not in Alaska.
so I would, for that pressure specifically, I'm gonna go ahead and call the doc again. She's on the phone and see what I could do. Choices, my thought process, the only thing that could vasodilate would be nitro to get his pressure down. However, if it's a bleed, that's definitely not what we want to do. We could, with the heart rate that, yeah, I'm just gonna call the doc, see what they say. Hi, Dr. Wright.
Hi again.
Hi, I've got a blood pressure on this patient of 250 over 150, and it's becoming problematic. I need to get his pressure down and his heart rate up. I do have 3% going, and he's had 2 of Versed, but we aren't getting very far. Do you have any suggestions on how we could bring the pressure down?
What was his heart rate?
40.
It's unfortunate.
Super unfortunate.
I'd lean towards a calcium channel blocker, cardine, over a beta blocker, given his hypotension. So probably would try to start with some cardine. Also, the nasal intubation can be extremely painful and noxious to patients, even if he does have a low GCS. So I would also consider some sedation for him. You could go benzos, but I would also give him some fentanyl. Make sure that we're taking away any painful stimuli that may be contributing to his hypertension, although I suspect it's from impending herniation. But I would say cardine, go ahead and start a cardine drip and watch that blood, watch that heart rate, and add some sedation. Go from there.
Cardine's
right.
an amazing idea.
So he magically arrives to the ED. You don't have to give report. You already know about the patient because you talked to her on the phone. He's a lot better. Apologies for the barking in the background. He's a lot better. His rate is 112. He's 98 over 60. And otherwise is ventilated and setting appropriately. Dr. Wright, anything else for the good of the order in the ED? What would you do?
I would call a neurosurgeon and see how quickly they could get to the bedside. I mean, I think intracranial hemorrhage is the number one thing on my differential, given these hemodynamics in the setting of this clinical picture. I worry, of course, about other traumatic causes or other traumatic injuries from his fall. Worry about a C-spine injury. I'm sure he had a collar on. He was never hypotensive. Certainly we did the 12 lead, but we think about with bradycardia, did he get bradycardic and then fall, or is he bradycardic because he's bleeding into his brain? But at this point, we're chasing our tails with numbers and vital signs, and what he probably needs is definitive surgical intervention to get better. And I would switch out his tube to an oral tube.
Yes, excellent management, everybody. This was indeed the case of somebody who has a head bleed and increased ICP. And it's taken up too much space in that closed cranial vault, right? There's only so much more room, and the brain can take up a lot of it with the CSF and blood vessels and everything else. This is the Monroe Kelly doctrine, if I remember correctly, is what this is. So there's only so much room. If you add stuff to it, it's going to increase the pressure and push stuff downwards, including herniation, causing that triad that you guys talked about, the Cushing's triad. So this patient had it all, had bradycardia and hypertension, had widening pulse pressures, and then was very sick, very, very, very sick guy. You basically nailed all the treatment that I wanted you to get. So obviously this person needs a CT scan and goes directly to the operating room. But in the meantime, while you're kind of waiting for that, you're doing the temporizing measures, right? You're doing the mannitol or the 3%. That's going to help decrease the swelling a little bit and hopefully kind of slow down that herniation. You obviously went really good aggressive airway management. There's that trial out of Arizona that has recently shown us that in patients with head injuries, you really focus on oxygenation. Even hyperoxygenation is okay in these folks. You really want to focus on appropriate ventilation. You don't want to ventilate them too fast. And then you really want to make sure their blood pressure is okay. Obviously, this guy had plenty of blood pressure to go, so you don't have to worry about that. But if they're hypotensive, that can also be bad sometimes until you have a CT scan and know definitively what's going on. So yeah, those are the big stuff. The only thing I would add is you can elevate the head of bed to 30 degrees. That maybe can help support some drainage too as well. If you're transporting in the back of a helicopter and it's a tight squeeze, do your best with that. And if they're a really tall person, but that is all I have.
I have a question.
Yeah.
And I love you, Ryan. Do you feel like a nasal intubation is the best route if there is increased ICP?
So it's a good question. I guess I will cheat and say, if the plan is to get critical care on scene who has RSI, if you feel like you're appropriately managing the patient's airway with BLS measures and the flight crew is 5-10 minutes out or whatever, reasonable amount of time out, I think it's okay to continue managing with BLS measures. If you need the hands and you don't have RSI and the patient has a gag reflex, but he's not protecting his airway, then obviously airway is going to come first. And so that's what's going to kill him first. So if that's the only way you have to manage the airway, then go ahead and do it. I learned EMS not in Colorado and had never seen a nasal intubation actually done pre-hospital until I came here. So it's a special thing we have here. But I think it's kind of a decision choice on what's going to kill him first. If it's the airway and I can't manage a BLS, then absolutely. If I have some time, can do some temporizing measures until RSI capabilities, then I think it's okay to do BLS as well. Dr. Wright, do you agree?
I do. I give Ryan a hard time, and I give everybody a hard time about nasal intubations because I hate them. But I will add, there is a time and a place where if there are no other sufficient alternative ways to manage oxygenation and ventilation in a critically ill patient, it is an acceptable tool to use. Mandy, to your point, nasal intubation is painful, it's uncomfortable, and the concern is it can increase ICP if there's a head trauma. That being said, the theoretical increase of ICP, like we see with ketamine and stuff like that, can increase that number on like an ICP like detector, but often doesn't correlate with like significantly clinical differences. I think that I put in the chat this picture from the EPIC trial that Andra was referring to, and really incredibly done trial. And the 3 most dangerous things that can kill patients faster with TBIs are if they become hypoxic, if they become hypotensive, or if we hyperventilate them. So if you need a definitive airway to control those measures precisely, then, and that's your best bet. Fine. Do I like it? No. Will I give you immense amount of crap about it? Always. But at the end of the day, what's going to kill him first? Sure, we can, if we have a QI conversation about it and Ryan can give me his rationale, he had a gag, he was seizing, I couldn't get an airway, I sunk a nasal tube, then I will say, good job, sir. Please don't ever do it again. I think a lot of us are burned by nasal tubes, quite honestly, because we've all seen systems that do them in every intoxicated patient just to prove that they can, right? And so I think there's kind of this, I have a visceral reaction to it. But I think there probably is a time and a place. So I will never say never, but I won't like it.
I would stand by my decision.
I support you, right? I'm saying I support you.
No, this is, and folks, this is kind of the purpose of doing these types of education models. There is definitely a little bit of gray and a lot of science behind it. So I think these conversations are what we actually glean the most from. And, I think when you're on the edge and you make that clinical decision, you can't do it from an egocentric standpoint. You have to be able to sit there and show documented SAT drops, patient deterioration, and have a solid justification for what you're doing. Regardless of what you do in medicine, it's very easy to kind of take the opposite stance. And that is what pushes this craft forward. And I think this exact case showed just that. So the debate is always welcome, and in your agencies always have those debates because that's where the learning actually happens.
Couldn't have put it better myself. Well done.
Dr. Wright and Dr. Farkas, do you prefer your clinicians to bring in your neuro patients with the head of the bed elevated a little bit to like 30 degrees? Is that a thing? Is that like bonus points? Is that like a yes, please do?
It's a yes if you're certain they don't have any other spinal fractures, and that's where it gets tricky. So I think that's kind of the trade-off. It's fine if it's a C-spine in a head, but if it's a thoracic lumbar in a head, then we have to be careful about having them in anything else besides supine. But again, what's going to kill them first? I say raise the head of the bed. Use gravity to your favor.
And what about end tidal? We want that targeted at 30 to 35 versus the 35 to 45 because of the increased ICP, or no?
Still 35 to 45. We used to hyperventilate in head injuries, but I think that's been, with the EPIC trial, that's been kind of debunked, so to speak. So I think just maintaining that normal 35 to 45 is ideal. Yes, the Dillinghams want to talk about, I don't know which of the Dillinghams, want to talk about blood pressure management. So go ahead.
This Dillingham is Kaylee, but there is a third Dillingham here. I just have a question about like what's an ideal blood pressure in a head injury patient? Because I realize that there's competing pressures when you have a patient who possibly is A, herniating, or B, bleeding out into their head. That there's like a certain level of pressure that's competing against the blood pressure. Right. So I guess I'm not really sure what's like I realize like we want to keep the systolic blood pressure above 90, but like what's an ideal pressure in this to maintain so that their brain is still perfusing? Does that make sense? Okay.
Yes, Kaylee, you just perfectly described what's called the cerebral perfusion pressure. And that's the pressure that the body has to have to maintain cerebral perfusion and overcome other pressures that might exist in the skull. In polytrauma, exactly like you identified, it's a little more complicated. You want that systolic to be above 90. In our isolated head trauma patients, I think most of our neurosurgeons want it, what is it, below 140, Andra?
Yeah,
Is the latest.
The neurosurgery place, because I've worked at a couple places that have different, some say 160, some say 140, but I think more recently we moved towards more aggressive, less, or at least at university we moved towards more aggressive, less than 140. I've definitely seen less than 160 though as well.
Yeah, so I think it's between 90 and 140 would be your goal range for systolic blood pressure in your head trauma patient.
Okay. Thank you.
Great question. All right.
Anything else? Any other questions, guys, comments, concerns, complaints?
Feedback, thoughts on the format?
Love it.
Oh, I do have a question. This is
Still muted.
No,
No,
you're
you're
good.
this is John Dillingham. Hey, just can you go over why TXA would or would not be an consideration in this?
Dr. Wright laughs.
I know you're laughing, but maybe you can put that out there in the world.
I will let you talk while I can link the trials while you're talking.
Okay, fine, perfect. So the TXA, I think John's trying to give me a stroke. The TXA is not, it did not pan out in isolated head trauma in the way that it did with hemorrhagic shock from other body cavities. Andra is maybe going to throw the clinical trials in there. I forget which of the crashes took, took the TBI group. It was a crash 3 based on the fact that you just put that in the chat. Isolated out the TBI group. Can you not? Sorry. I'm getting attacked by a dog. And essentially, I don't know that it increased mortality, Andra, as much as it did just not help patients with isolated head. So I think it becomes one of those things that, sure, if you've got a long transport and you want to call and talk about it, it's not the wrong question to ask, but it didn't help patients and it may have tended more towards harm in patients with isolated head. Farkas?
Yeah, basically the risk of head injury related death reduced with tranexamic acid with mild to moderate, but it didn't do anything in patients with severe head injury, basically. Yeah, so basically it didn't do anything for the severe head injury patients. And then I think the risk of kind of clotting and stuff was pretty similar. That was the TLDR. I'll put in the actual trial in the chat as well.
Thank you.
Hey, and thanks to all the participants. I know it's a lot to put yourself out there and be judged by your peers. We really appreciate you guys doing this.
You guys did so good. It was perfect. I promise they didn't know the cases beforehand.
We did not. We have a text thread of me cursing Andra for pediatric cases to prove it.